class. Let's continue the lecture with part 2 of chapter 26. So these are the learning objectives for part 2 of chapter 26. Everything in this learning objectives we will cover in part 2. So epistaxis or nosebleed. Due to numerous capillaries within the nose tends to bleed more often. Why does a patient experience nosebleed? This may be due from a trauma, hypertension, blood dyscrasia. This is a pathological condition of the blood, such as leukemia. This is a type of cancer. Leukemia is a type of cancer that starts in the blood-forming cells of the bone marrow, and then invades the blood. Other factors include tumors, inflammation, decreased humidity, nose picking, chronic cocaine use, and nasogastric suctioning. The patient often reports that the nosebleed starts after sneezing or blowing the nose. Please review for your information the box entitled Best Practice for Patient Safety and Quality Care, Emergency Care for a Patient with an Anterior Nosebleed on page 522. And that's for your information. Children also experience nosebleed for a short, isolated occurrences and are common in children ages 3 to 10-year-old. My granddaughter is 8 and she's going to be 9 in November, God spare her life, and she's been having nosebleeds. The last episode was really terrible. She cupped her hands and those were really filled up with blood, bright red blood. She eventually had to go to the pediatrician and they did some lab work and things like that. Most nosebleeds in children are caused by nose picking or dry air. However, trauma, low humidity, allergic rhinitis, and that's what they're thinking that she has, upper respiratory infection, blunt injury, or a foreign body in the nose, as well as medications that affect clotting factors can increase or precipitate a nosebleed in children. Of the medical measures in the box on page 522, if the medical measures in the box on page 522 are not effective in a patient with an anterior nosebleed, then the affected capillaries may be cauterized. This is the use of a heated instrument to burn the area to stop the bleeding, such as silver nitrate or electrocautery, and the nose packed. That's another way of stopping the bleeding. Posterior nasal bleeding is an emergency because it is difficult to stop the bleeding, and during this time the patient may lose a lot of blood. The use of posterior packing, epistaxis catheters, which these are nasal pressure tubes, or gel tampons are used to control posterior nasal bleeding. The posterior packing is done by the healthcare provider, who places a large gauze packing in the posterior nasal cavity above the throat. The attached string is threaded through the nose, and this thread is taped to the patient's cheek to prevent the packing from moving. Epistaxis catheters look like urinary catheters, but they are shorter, about 6 inches long. The airway may become obstructed, causing inadequate gas exchange if the packing or pressure tubes slip out of place. While the tubes are in place, the nurse will assess the patient for respiratory distress, such as dyspnea, and observe if the patient is tolerating the packing or tubes. A humidifier, oxygen, bed rest, and antibiotics may be prescribed by the healthcare provider, as well as opioids for pain. If posterior bleeding does not respond to packing or tubes, then additional options include cauterizing or ligating the blood vessels or an embolization of the bleeding. of the bleeding arteries performed by the interventional radiologist or IR. Facial pain, loss of tissue integrity with necrosis of skin or nasal mucosa, facial nerve paralysis, and blindness are potential complications of an embolization. An embolization refers to a procedure that uses particles such as tiny gelatin sponges or beads to block a blood vessel, thus stopping it from bleeding. After the tubes or packing are removed, teach the patient and family or caregiver to use petroleum jelly sparingly to the nares for comfort. Use saline sprays after healing to add moisture and prevent bleeding. Also teach a patient to avoid vigorous nose bleeding. Avoid the use of aspirin or other non-steroidal anti-inflammatory drugs because these will promote bleeding. And strenuous activities such as heavy lifting for at least 1 month. Let's discuss fractures of the nose. Injury to the nose may result in loss of tissue integrity. Nasal fractures interfere with gas exchange. Why? Because airflow is impaired and the patient has difficulty breathing. And so they would not be able to exchange that gas. They wouldn't be able to exchange that oxygen coming in and get that carbon dioxide out. The nasal fracture may or may not displace the bone or cartilage. Therefore, if there is no displacement of the bone or cartilage, treatment will not be necessary. However, if there is displacement, treatment will be necessary, as this can cause airway obstruction or cosmetic deformity, and is a potential source of infection. During the assessment, be sure to document any deviation, any change in nasal breathing, unalignment of the nasal bridge, any crepitus, which is crackling of the skin, on palpation, bruising and pain, and also of blood, so you document bruising and pain. Now, if blood or clear fluid, cerebrospinal fluid, drain from one or both nares from a simple nasal fracture, this indicates a serious condition, and it's always skull fracture. Don't forget this. If blood or clear fluid, which is the cerebrospinal fluid, if the cerebrospinal fluid is draining from one or both nares from a simple nasal fracture, this indicates a serious condition, and it indicates skull fracture. So to distinguish CSF from normal nasal secretions, use a dipstick that is used for glucose testing, and the CSF will test positive. Why is that? Because CSF contains glucose. You need to know this again. Okay? Some surgical interventions that the surgeon will perform for a fractured nose include closed reduction, and this is a procedure that reduces the displacement by setting the bones back in place, which is done by palpation to realign the bones. It is best to do this procedure within the first 24 hours after injury, because after 24 hours it is difficult to reduce the displacement due to edema and scar formation. If the procedure is done after 24 hours, the surgeon may have to delay the surgery until the swelling is gone. And management for the procedure focuses on pain relief and decrease the swelling. Rhinoplasty, and this is one of the objectives, it describes the post-op care for patient with a rhinoplasty procedure. This is another procedure that's done for severe fracture of the nose or for those that do not heal properly. Rhinoplasty is a surgical reconstruction of the nose. That is a plastic surgery procedure for correcting or reconstructing the shape of the nose. The patient will have nasal packing in both nostrils after surgery to prevent bleeding and provide support for the reconstructed nose with packing. The nurses do not remove the packing. Nurses can change the drip pad and also teach the patient to change the drip pad, but nurses do not remove the nasal packing. The surgeon will do that. Therefore, the patient, so the patient will also have a moustache, I never can call this word properly, but you know what I'm talking about, it's a moustache. Um, Dressing, my husband always laughs at me because I say it differently. And he is, well, he's gone now and it's very sad. But he was from the state of Missouri, and he always made fun of me with this word. So they'll have that dressing or drip pad placed under the nose, and this is a folded 2x2 gauze pad that is used as a drip pad. See figure 26-3 on page 523 for a picture of a drip pad. A splint or cast may cover the nose for better alignment and protection. Teach or change the drip pad. Teach the patient or how to change it, or the nurse will change the drip pad as needed. If the patient has repeated swallowing, this may indicate posterior nasal bleeding. Use a pen light to examine the throat for bleeding and notify the surgeon if bleeding is present. Okay. Now we're going to talk about the post-operative care after rhinoplasty. Post-operative care, observe for edema and bleeding. So you observe for edema and bleeding from loss of tissue integrity. The patient may discharge the same day if the rhinoplasty was uncomplicated. But if there's complications, the patient will um, be tended with observation. Most of the patients that I see on the general surgical floor, they overnight. However, whether the patient was discharged the day of surgery or remained in the hospital overnight, the nurse will teach the patient to keep the bed in a semi-forward position, and this means that the patient lies on his or her back with legs straightened or bent, and the head of bed is set between 30 and 45 degrees angle. So, for postoperative care, the patient, you're going to observe for edema. Let's see. Right, observe for edema and bleeding from loss of tissue integrity. And the patient's head is going to be placed, the patient will be in a semi-forward position with the head of the bed between 30 and 45 degrees angle. Instruct the patient to move slowly to prevent any dizziness. Use cold compresses on the nose, eyes, and face to reduce swelling and bruising. After gag reflex return, encourage the patient to drink about 2,500 mLs of liquid per day and eat soft foods, like applesauce, mashed potatoes. Teach the patient to minimize valsalva maneuver, such as forceful coughing or straining during a bowel movement. So you don't want him to have that forceful coughing or straining during a bowel movement. Not to sniff upward or blow the nose, and not to sneeze with the mouth closed for the first few days after the packing is removed. Why? This is to prevent bleeding. Instruct the patient to prevent bleeding by avoiding the use of aspirin and other NSAIDs such as ibuprofen and naproxen, as these will cause bleeding. However, the patient can use an alternative analgesic for pain, such as acetaminophen or Tylenol, instead of these drugs. Encourage the patient to complete the prescribed antibiotics and to use a humidifier to prevent drying of the mucous membrane. Explain to the patient that because of edema, Noticeable result of the surgery may take about 6 to 12 months. Wow. For nasal septoplasty or submucous section, um, and I'm going to look into that and make sure it's not 6 to 12 weeks. The book says 6 to 12 months, but I'm going to double check on that. Nasal septoplasty or submucous section, SMR. This is a corrective surgical procedure done to straighten a deviated or deformed nasal septum when there are chronic symptoms and discomfort occurs. The nasal septum is the partition between the nasal cavities, the two nasal cavities. The deviated section of cartilage and bone is removed and reshaped and is done as an ambulatory surgery. The nursing care is the same as with a patient with rhinoplasty surgery. Again, know the post-op care well for patient with rhinoplasty. And again, I did refer to this earlier, but that's the image to the right showing bandaging after a rhinoplasty. And we have humidifier there. I don't remember I said that, but the patient will use a humidifier. If I didn't say that, the patient will use a humidifier in the room to help with to prevent the dryness and to give some moisture, and that's why they will use a humidifier. Okay, facial trauma and nasal fracture is a facial fracture as well. When taking care of a patient with facial trauma, the nurse's number one priority action is airway assessment. Don't forget this. So why is airway assessment is the number one priority action? Airway obstruction can cause impaired gas exchange. Signs of airway obstruction include stridor. This is an adventitious long sound, which is a harsh vibrating noise when breathing. Shortness of breath or dyspnea, also facial trauma signs and symptoms. The patient may be anxious and restless, have hypoxia, which is a deficiency in the amount of oxygen reaching to the tissues, hypercarbia, elevated levels of CO2, decreased O2 sat, cyanosis, and eventually the patient has a loss of consciousness. So these are the signs of symptoms, airway obstruction in a patient with facial trauma. Okay, so when they have all these signs and symptoms, we know that the patient has obstruction, and so airway assessment is the number one priority. Le Fort fracture. These are facial fractures, and a nasal-ethmoid complex fracture is a Le Fort fracture. And a maxillary and nasal-ethmoid complex fracture, that's called Le Fort 2. And Le Fort 1, you see on your right, the nasal-ethmoid complex fracture there, and then down to the bottom there is Le Fort number 2, which is maxillary and nasal-ethmoid complex fracture. So again, a nasal fracture is a facial fracture. Okay, so Le Fort 3 is what you're seeing here to the right. It's a combination of Le Fort 1 and 2 plus orbital zygoma fracture, often called craniofacial disjunction. So assessing the patient with Le Fort fracture, again, airway. Maintaining an adequate airway is the number one priority for a patient with facial trauma. The nurse is or healthcare provider would assess the trauma site for bleeding, assess the patient's vision and eye movement. Why? Because orbital and maxillary fractures can entrap the eye nerves and muscles. check behind the ears, like the mastoid process, for extensive bruising, known as the battle sign. And if you find that battle sign, it's often associated with skull fracture and brain trauma. The healthcare provider will order a series of imaging, which includes um, cranial CT and also facial series and cervical spine X-rays, because facial trauma can cause. Let's back up. The healthcare provider will order a series of imaging which include cranial CT, facial series, and cervical spine X-rays. And why? Because the facial trauma can occur with spinal trauma and skull fractures, and that's why they order all these, because facial trauma can occur with spinal trauma and skull fractures. So these are some interventions for Lafont fracture. Intervention, again, the number one priority action is to establish and maintain an airway for adequate gas exchange. In this situation, the nurse would anticipate the need for an emergency intubation. That is the insertion of a tube into the trachea for ventilation or to open up the airway. Tracheostomy. They also will do a tracheostomy. So they'll do intubation, a tracheostomy, or for a cricothyroidotomy. Therefore, the care at first would be focused on establishing an airway, then control bleeding, and assess the patient for the extent of the injury. Time is of essence in stabilizing the patient who has had a neck fracture. Therefore, stabilizing the fractured jaw, if present, allows the teeth to heal in proper alignment and involves fixed occlusion. Fixed occlusion is wiring the jaws together with the mouth in a closed position. The patient remains in fixed occlusion for about 6 to 10 weeks. Surgery may be needed if the patient has extensive jaw fractures and an open reduction with internal fixation, ORIF procedure is done. And this is a procedure performed to fix severely broken bones and is done for serious fractures that cannot be treated with a cast or splint. And these fractures are usually displaced and unstable. Laryngeal trauma and damage usually result from a crushing or direct blow injury. Fracture, below injury fracture, sorry about that, or prolonged endotracheal intubation. So laryngeal trauma and damage usually result from a crushing or direct blow injury, from a fracture or prolonged endotracheal intubation with loss of tissue integrity. The patient presents with difficulty breathing, apnea, the patient presents with difficulty breathing, aphonia, which is the inability to produce sound. I know this lady who just developed that problem, where she cannot present any sound at all. She has to write, which is the inability to produce sound. Also, the patient will have hoarseness and subcutaneous emphysema, which is air present in the subcutaneous tissue or under the skin. Depending on the location of the trauma, the patient may have bleeding from the airway as well. The healthcare provider will perform laryngoscopy, which is direct into the larynx, or they might do a fiber octave laryngoscopy to determine the extent of the injury. Management includes assessing the effectiveness of gas exchange and monitoring vital signs, which include the respiratory status and pulse oximetry every 15 to 30 minutes. And again, of course, maintaining A patent airway is the number one priority. And then oxygen and humidification will be ordered by the MD to maintain an adequate oxygen saturation and also for moist ear, not dry ear. I would like you to stop the tape and complete the NCLEX examination challenge question 26-3 on page 524. Cancer of the nose and sinuses. Tumors of the nasal cavities and sinuses occur from the inability of the function of cells to maintain homeostasis. This is cellular regulation. Tumors in the nose are mostly benign, and malignant tumors are rare but can occur in adults. If a patient has a malignant tumor of the nose and sinuses, it is due to the individual's exposure to dust from wood, textiles, leather, flour, nickel, chromium, mustard gas, radium, and cigarette smoking. The nose and sinuses tumors are slow growing, and the patient may be misdiagnosed with sinusitis because the signs and symptoms resemble sinusitis, which include persistent nasal obstruction, drainage, bloody discharge, persistent pain. Despite treatment of sinusitis, the lymph nodes become enlarged at the site of the tumor. So these are some signs and symptoms. X-ray, CT, or MRI imaging are used to identify the tumor, and a biopsy is performed to verify the diagnosis. The primary treatment for nasopharyngeal cancer is to surgically remove the tumor, which may be combined with chemotherapy and intensity modulated radiation therapy, or IMRT. Head and neck cancer. One of the objectives says to identify the warning signs for head and neck cancer. Head and neck cancers are classified as squamous cell carcinoma, and this carcinoma is the most common type of cancer, which starts in the epithelial tissue of the skin or in the tissue that lines internal organs, such as the liver or kidney. These types of cancer are slow growing and have a good survival rate when diagnosed and treated at an early stage. Patients usually do not survive past 2 years of diagnosis if the cancer is left untreated. Head and neck cancer begins with the loss of cellular function to maintain homeostasis. Cellular regulation refers to all functions carried out within the cells to maintain homeostasis. In neck cancer, the cancer starts out with a loss of cellular regulation as evidenced by chronically irritated mucosa that becomes tougher and thicker, known as squamous metaplasia. This causes damage to the genes that control cell growth, and as a result, there is an abnormally excessive growth of these cells, a lot of proliferation, that becomes malignant, and malignant is deadly. The lesions are seen as white patchy lesions, as leukoplakia, or red velvety patches known as erythroplakia. And these are, then the cancer spreads or metastasizes into the local lymph nodes, muscle bone, and then later to distant sites such as the liver and lungs. Tobacco and alcohol use, particularly if they are used together, are the two major risk factors for head and neck cancer. Others include what you see listed on the slide here. I would not read them out to you. But what is very interesting is that a positive human papillomavirus, or HPV, these long words, human papillomavirus, or HPV, Patients have a much higher overall survival rate when they have a positive HPV than when a patient has a negative HPV at the same stage. About 68,000 new cases of oral, pharyngeal, and laryngeal cancers are diagnosed each year in North America, and about 14,000 deaths per year. Men are affected twice as much as women, and head and neck cancers are most common in adults older than 60 years of age. Okay. So when assessing a patient for head and neck cancer, the nurse or healthcare provider would ask the patient about tobacco and alcohol use, because we said those were the two major risk factors there. We mentioned in the previous slide, yes, that alcohol and tobacco, especially if used together, are the two major risk factors for head and neck cancer. So the nurse will also ask about other risk factors that were listed on the previous slide as well. Ask a patient about history of acute or chronic laryngitis or pharyngitis, oral sores, difficulty swallowing, and any lumps in the neck. Calculate the patient's smoking history in past years. We discussed this in chapter 24. Also ask about oral exposure to HPV. Physical assessment and signs and symptoms. Laryngeal cancer manifests itself with painless hoarseness due to the size of the tumor. Any adult who has a history of hoarseness or change in voice quality, they have mouth sores or a lump in the neck for 3 to 4 weeks, should be evaluated for laryngeal cancer. Please make table 26-1 on page 526 your friend. Warning signs of head and neck cancer. Table 26-1 on page 526 your best friend. Warning signs of head and neck cancer. And these are the imaging for assessment to diagnose head and neck cancer. Various types of imaging studies include x-rays of the skull, sinuses, neck, and chest. And these are ordered by the healthcare provider to diagnose the cancer and the cancer spread, and also the extent of the tumor invasion. Because other studies include CT with contrast, MRI, nuclear imaging such as single photon emission computed tomography, and that is the SPECT, and the position emission tomography, which is the tomography CT, which is a PET-CT. I don't know if you've heard of a PET scan, and the doctor would order PET scan. This will tell the doctor the stage, or it will stage the cancer, tell you how extensive this cancer is, as well as if there's any metastatic sites as well with that PET scan. Radiation, these are some other treatments. There are several ways to treat head and neck cancer. The focus of treatment is to remove or eradicate the cancer while preserving as much function as possible. These treatments listed on the slide may be used alone or in combination, depending on the stage of the cancer, the general health of the patient, the patient's nutrition status, their age, and also the patient's personal choice. Radiation therapy, Linda went through this and chemotherapy in chapter 20 with you guys. But just to recap, it's used to treat small cancers in certain areas. And the 9th edition says 80% chance of curing the cancer. And now the 10th edition is saying 40%. I know they do have some errors in the book at times, because the question, I took the question out because the question was saying 80%, whereas that was in the 9th edition. And then now it has 40%, but I will do some research on that to see what's the evidence base at this time. For now, the book says 40%, but I'm not going to answer any question on that. Some side effects of radiation therapy include hoarseness, difficulty swallowing, skin problems such as redness and tenderness, lack of taste in the mouth, and dry mouth. So the nurse would want to instruct the patient to avoid exposing the reddened area to the sun, and also to heat, cold, and not to shave this area. Teach a patient to wear protective clothing made of soft cotton and to wash this area gently with a mild soap daily. There is a high risk for dental problems such as dental caries, oral infection, bad breath, and changes pertaining to these. So because of these risks, the patient will need a dental consultation to assist with these problems. Well, changes pertaining to taste. Chemotherapy may be used alone or in combination with surgery or radiation therapy. And most of the times I see chemotherapy and radiation therapy. So chemoradiation, which is a combination of chemotherapy, like I said, is mostly used. The most common chemo drugs used to treat head and neck cancer include cisplatin in combination with 5-FU or fluorouracil. It's FLUOROURACIL. I'm not going to answer that. Biotherapy. This treatment involves the drug cetuximab, and this drug blocks epidermal growth factors receptors. And like I said, Linda went over radiation and chemotherapy with you guys in chapter 20. So let us continue with surgical interventions. Surgical interventions includes cordectomy, and this is the removal of a vocal cord, and a partial or total laryngectomy. A partial laryngectomy is the removal of a portion or part of the larynx or voice box, and total is the removal of the entire larynx or voice box. If the cancer spreads to the lymph node, then a nodal neck dissection along with the removal of the tumor is performed. Lymph node dissection is the removal of the lymph nodes, and a sample of tissue is sent to the lab for inspection for cancer cells. Okay, I'm going to end part 2 of chapter 26 on this slide. I would like you to read the pages that cover these slides, which is page 526 to 529, and also complete the case study, answering the questions, and there's one question at the end of the slide as well, the lecture, and complete the learning objectives for this part of the lecture. And I will see you in the next lecture, which is chapter 27.